Okay, so we left off. We're going to talk about color flow ultrasound. So this is takes advantage of what we just learned about sound interacting with matter and the Doppler effect. And this is visually how you can get information when you ultrasound a blood vessel, and you can get some information by looking at it and what color that blood vessel is going to show up with on the machine. So color flow ultrasound, again, is an option that majority of ultrasound machines have. Some of the cheaper machines that you're going to buy, again, it's like with anything you buy, you tend to get what you pay for. And so some of the really cheap machines won't have color flow capability. And if they do, it's going to be really poor quality. But the majority of machines nowadays will have some type of color flow option that you can get. There's two types of color flow. There's standard color flow, and there's what's called power Doppler. Depending on the vendor, they may call the power Doppler something else, but it's really called power Doppler. The standard color flow is what you think of when you have seen ultrasound images and you see color flow. That's the reds and the blues. Okay, the power Doppler just shows you one color. It's just kind of reds. Okay, so let's look at the difference between those two. Okay, so this is standard color flow Doppler. So here's an ultrasound. This is a picture of the liver. The ultrasound probe's on top of the animal. This white area right in the top up in here is the skin and maybe some subcutaneous fat. So this is liver area, and inside the liver I see these blood vessels. So the blood vessels show up kind of black. Okay, there's some more up in here. If I turn the button on and I show color flow, then I see this blood vessel overall is red. This blood vessel up here and its branches overall are blue. Okay, so what makes the difference? Well, what you have to do is remember this acronym that stands of BART, and that stands for not for Bart Simpson, but that stands for blue away, red towards. Okay, and so the color is depending on where the probe is. Okay, so again, our probe is up here on the top. Okay, and so anything that shows up blue on the ultrasound, blue means away. So this blood direction, the direction of blood flow inside this vessel is going away from the probe, blue away. So the direction of flow in this vessel is going from the top to the bottom. So blood flow in this blue vessel is going from this direction to that direction, away from the probe. Okay. On the other hand, blue away, red towards everything that's red. Now the blood flow in this vessel is going from this direction towards the probe. Okay, blue away, red towards. The blues and the reds have nothing to do if it's an artery or vein. It has nothing to do with how hot the blood is. I had one student ask me that one time. It has nothing to do with, it's not thermography. It doesn't have anything to do with the heat of the blood vessels. Okay. So it has everything to do with the direction, blue away, red towards. So you want to remember that acronym BART. Okay. So now by looking at this, I can tell the direction of blood flow. If I put a little cursor in the middle of that vessel, I can tell the velocity of the blood flow with standard blood Doppler. And by using the Bernoulli equation, I can convert that into pressure. So it's very useful. Okay, non-invasively now, I can tell, number one, is there flow in that blood vessel? I can tell the direction of flow by what color it is. And if I put a cursor in there, I can tell exactly the velocity of flow, which then I can derive the blood pressure. So I get all of that information out of this Doppler ultrasound exam. Okay. On the other hand, the other type of Doppler is called power Doppler. We did say a minute ago that if you look at standard color flow Doppler like this, what is that Doppler signal? What's the most dependent variable that it depends on? And that the answer to that would be the velocity of flow. Again, if the velocity is really slow, then we don't get much of a Doppler signal. Okay, the faster the blood flow in that vessel, we get a better Doppler signal, which means we get more defined color. Okay, so there becomes a point where you get such slow flow in a vessel, some of the veins, that you really can't get a very good Doppler signal. Okay, well, that's where power Doppler comes in. So power Doppler is really good for looking at slow flow, okay, in veins, almost down to the perfusion level. This is a testicle, and you can see all of this slow flow into the perfusion level of that tissue. Okay. The power Doppler does not tell you what direction the blood flow is. It doesn't tell you the velocity of the blood flow. It just tells you there is flow, and it's slow flow. Okay, which can be also very useful because there's been lots of studies over the year have done by analyzing the pattern of perfusion. Can we try to predict if there's a nodule in there? If it has no blood flow, is it dead? Is it those tissues dead, dying? Is it cancer? Is it not cancer? By looking at the pattern of blood flow on power Doppler. Okay, so conventional Doppler, typical Doppler, the reds and the blues, the BART, that's what you're going to use a lot to tell blood flow and direction of blood flow. Is there blood flow in a vessel and things like that? The power flow, you're going to look at very slow flow. You won't use it anywhere near as much, but it's still very important to know at least that tissue is being perfused. It's getting a blood supply. Okay. Okay, then we're going to move on and we're going to talk about a couple of words, a couple of definitions, just so we're all on the same page. Something on that is described as being hyperechoic. So let's imagine you have a nodule inside the liver and you see it with your ultrasound machine. Okay, if that nodule shows up bright white, okay, you say that nodule is hyperechoic, meaning literally echoes of sound and hyper. So too many or hyperechoic sound. It shows up bright white. Okay. If it shows up darker, that nodule on ultrasound than the surrounding tissue, you would describe that nodule as being hypoechoic. So not enough echoes or not enough sound. So it's hypoechoic. Something that is anechoic would be something that is totally black on ultrasound. So what are some things that would show up anechoic on ultrasound or totally black? Well, normal urine inside the urinary bladder would be totally black. Okay. Normal bile inside the gallbladder would be totally black. Okay. Blood vessel, if you don't have color flow on, if you image a blood vessel, an artery or vein, it's going to show up totally black because it's full of fluid. So basically anything that is full of just fluid like water is going to show up totally black on ultrasound. Okay. All of the tissues in the body are going to show up some shade of gray. Okay. A varying shade of gray depending on what tissue that is. Okay. If things are isoechoic, that's a relative term used to describe two nodules and compare them to each other. So if nodule A is the exact same shade of gray as nodule B, you can say those two nodules are isoechoic to each other. They have the same echogenicity. Okay. We also mentioned this near field and far field concept. The near field is something that is closest in the tissues to the probe, and that's where we get our best picture with the best resolution. Okay. The far field is everything that's deeper in the tissues, and that's where our picture starts to kind of traditionally fall apart. We get poorer quality images just because of the waveform of energy, and it diverges, it dissipates, it's being absorbed by the soft tissues in the far field. Okay, so what's some general statements about what ultrasound can do for you once you learn ultrasound in your practice and start doing ultrasound? Well, again, unlike radiographs, ultrasound is invaluable for looking inside of the abdominal organs. So it's really good for looking inside the liver. Okay, radiographs do nothing to look inside the organ. Ultrasound, that's where ultrasound comes in. It's really good to look inside the organs. Okay. On the other hand, ultrasound is like most imaging modalities, it's highly sensitive, but also highly nonspecific. So what do I mean by that? I can tell you that with my ultrasound probe that there are 3 hyperechoic nodules in the liver. I can measure the diameter of those nodules. I can describe the blood flow in those nodules. So I can describe the hell out of those nodules. I can count them and do everything else, but do I know what they are? Do I know if they're benign or malignant? The answer to that is no. So almost all imaging modalities, including like MRI, you can describe the hell out of a lesion, but it doesn't really tell you, histologically, is that what it is? It doesn't tell you if it's benign, malignant, or exactly what it is. Now, having said that, we're going to spend the rest of the time talking about ultrasound, about how to narrow those choices down. And if you had to go make a bet in Vegas at the ultrasound craps table, how to narrow that down and make an intelligent, educated guess on that you can help with your clients. What do I think? Is this most likely benign? Is this most likely malignant kind of thing? Okay. If you have ultrasound and you know how to do the ultrasound, that's the key. it will allow you to diagnose more pathology than if you don't. Okay. In other words, if you have radiographs and you see the liver is big, you got your differentials for why the liver would be big and rounded in appearance, which we talked about already. But really, without looking inside the liver, I can't be more specific, and I can't diagnose and define mass just with an X-ray. So ultrasound will allow you to diagnose more pathology. Ultrasound is also best for focal or multifocal disease. Okay. The example of this inside the liver, if I have a big mass, neoplasm, cancer in the liver, and it's one big, large mass, typically it's that part of the liver is going to look totally different on ultrasound than the rest of the liver. Okay. So it's easy to see. On the other hand, there are some disease processes that can affect the liver and cause it to appear absolutely normal. It causes no derangement of the architecture of the liver at all. An example of that a lot of times would be mast cell disease, which is a cancer. Okay, it can live in the liver, but sonographically, the liver can look completely normal, but it doesn't mean it is normal. So it's sonographically normal, but you can still have abnormalities. An infection in the liver, hepatitis, sometimes the liver looks completely normal, but you'd have to stick a needle in it to know for sure it is. Okay. And the other thing is ultrasound, until you've done thousands of them, it's fun. It's kind of fun to do. It's a new toy. And that, when you get out and you graduate and you got to, your first year is going to be great. It's going to be exciting. But after that, it's a job. It's like any other job. Okay. It gets old. It gets boring. You don't want to go to work. You'd rather do something else. But that's what you got to do to make a living. Okay. So anytime you can, stimulate your mind a little bit more and get a new toy and something that makes you look forward to going to work, people use ultrasound for that too. Well, let's learn a new craft. Let's learn a new skill. Let's learn ultrasound. And so it's kind of fun to do. Okay, what can ultrasound do the opposite? What does it not do for you? Just because you go buy an ultrasound machine, you have to learn how to use it. And that's where unfortunately, a lot of clinicians fail. Is they'll go buy a nice $30,000 ultrasound machine, but they use it just to get urine and look for bladder stones. And they fail to make that next step of really learn how to really get the information out of that machine and really use it properly. Okay. Ultrasound will not differentiate benign versus malignant disease. There's no way in hell I can look at a mass inside the liver and tell you 100% for sure, is it malignant or benign? Okay. The only way to know that would be biopsy it, get some cells out of it, something like that, look it under the microscope. But even then, it's not 100%, but it's pretty close. Okay. Ultrasound, just because you have ultrasound doesn't mean you never have to shoot another X-ray. Okay. Again, that typical scenario, that vomiting Labrador that comes in on Friday night at 5 o'clock and vomiting, I would still recommend shooting X-rays first. That's your first diagnostic tool, is let's shoot some X-rays first, and then let's do an ultrasound if we need to after the X-rays. So it's not going to replace radiographs. It's not going to replace common sense things. It's not going to replace getting a history, talking to the owner, doing a physical exam, putting everything in context with the breed and the signalment of a dog and things like that. Okay. And again, just we talked about a minute ago with mast cell disease in the liver. Just because the liver may look normal doesn't mean it is. Okay, it looks sonographically normal, but there's some diseases that can happen in the liver and the spleen or whatever organ that doesn't cause it to appear abnormal on ultrasound. So it's not bulletproof. Okay, when you get ready to scan an animal, and unfortunately, Zoom-wise, it doesn't work out too well for us to do an ultrasound lab and scan an animal and put a probe in your hand. But a couple of things to keep in mind when you get ready to do one of these in your world is proper patient preparation, which is hard to say really fast, is essential. And so what do I mean by that? Well, you're going to get animals that are going to come in, and you're going to get people that are going to come in, and the owners with those animals, and they're going to say, you're palpating at mass in the abdomen of this dog. And you say, well, the next thing we need to do after we did our radiographs, we need to ultrasound it because we need to look inside the liver where this mass is coming from and see what it looks like and maybe get a biopsy of it. And the owner is going to say, well, what do you mean you have to clip the hair on the dog? Okay. Ultrasound does not penetrate through hair. It's got too much gas around it. No matter what you do, you're going to get a crappy image if you try to ultrasound an animal through hair, through fur. Okay. So you need to clip the hair on the belly like you're going to spay the animal. Okay. Like you're going to really down to the skin, you need to clip the hair. Okay. And you're going to get some owners that don't want you to do that. And that's when you have to decide, well, what kind of vet are you going to be? Are you going to be a half-ass vet that does things half-ass ways? Or are you going to stand up for what's medically right and say, you know, if you don't want me to clip the hair on your dog, I'm not going to get an image. So then we're not going to waste the time and money to ultrasound it unless you give us permission to clip the hair. Okay. So you need to clip the hair when you're getting ready to do an ultrasound. Okay, knobology, that means you have to study the knobs on your machine. You have to know how to work the knobs on your machine. So when to turn the gain up, when to adjust the depth. So ultrasound is a very interactive process where you're going to have one hand on the machine punching knobs, okay, and you're going to have another hand on the probe while you're looking up here at a monitor, okay? And you people that have grown up with, you know, video devices and playing video games and stuff like that, you definitely have an advantage because, you know, you are used to playing with the controller down here, but you're not looking at the controller. Okay. You're looking at the monitor of what the controller is doing. Okay. If you try to train older practitioners, even older than me, how to do this, they get really confused because they want to look at their hands. Okay, they want to look at what they're doing. And so they'll sit there and they'll stare at the dog's belly where the probe is. And you have to remind them, no, look up here. While you're doing that, you need to look up at the screen and see the effects of what you're doing. Okay. You want to orient yourself with the probe in the image. You want to know which side, when you're looking at that image, which side's cranial, which side's caudal, which side's right, which side's left. And if you start turning your probe around too much in different directions, you'll lose focus on where you're at. Okay, so you always want to keep in mind on which side's cranial, which side's caudal, and your orientation of the probe. You also want to scan the entire cavity for the most part. Okay, so if you have an animal that comes in and it doesn't feel right and he's vomiting, and you palpate a mass in the spleen on your physical exam, yeah, you're going to look at the spleen and you're going to confirm, do you feel a mass in there, what that mass looks like. But I think it's also important because we are veterinarians and these are animals that can't talk to us and they can't say what hurts and how long it's been happening. I think it's important, pretty much every exam you do, let's go ahead and scan the entire abdomen. Let's look at not just the spleen, but let's look at the liver and the kidneys and everything else in the abdomen and see if we see something else that's wrong, okay, while you're at it, okay? Very rarely you will do a focused ultrasound, like let's just look at the bladder and let's look at a stone. Or maybe you had a dog that had a tumor in the bladder and it got removed and he comes back 6 weeks later and you want to just look at the bladder and see if there's evidence that the tumor or the stone has come back. Then you can just do the bladder ultrasound. But for the most part in veterinary medicine, we typically want to scan the entire abdomen at the same time. The other thing I would tell you too is when you start scanning an animal, be systematic, okay? You want to have a routine for you and you want to basically do it the same way every time. And so you figure out for you what's the best starting point. Okay, I tend to start in the region of the urinary bladder just because when I started doing ultrasounds years and years ago, that bladder was easy to find. And so it gave me confidence right off the bat. I knew what I was doing. Okay. And so to this day, I start off with the bladder and then I make my way around the abdomen in a particular pattern. And, 30 years later, I do it the same way I did when I started off. Okay. The other thing I would tell you too is don't be wussy when you do your ultrasound. Okay. You need to apply enough pressure on the abdomen to where you can get a good image. Okay. So you don't just barely touch the probe to the abdominal wall. You tend to push down pretty darn hard into the abdomen, and that allows you to move gas-filled bowel loops out of the way. It puts your probe closer to the organ that you're trying to see, which makes the picture better. And so don't be afraid to push down pretty hard on the animal's abdominal wall. And again, ultrasound doesn't tell you what it is. It's not, specific. It doesn't tell you if it's benign or malignant. So for the most part, if you see something abnormal, don't be afraid to stick it. So put a needle in it, look at those cells under the microscope, do an aspirate, do a biopsy. Don't be afraid to stick it. There's about only one thing in the abdomen, I think, that people would tell you in general you do not want to put a needle in, and that's an adrenal gland. Okay, so I would stay away from sticking adrenal glands. Adrenal glands make lots of different hormones, and that can have bad effects. They're also next to big blood vessels and things like that, and they tend to be very small. And so you got to be real careful if you're going to stick an adrenal gland. So I pretty much stay away from adrenal glands when you're trying to stick things. Okay, artifacts. Before we get off into the exact specifics of disease processes in different organs, we have to talk about a couple of artifacts. Okay, ultrasound artifacts, we talked about there's some artifacts in radiology, but there's some in ultrasound. And the difference is in ultrasound artifacts, some of the artifacts that we see actually help us make a diagnosis. With radiographs, if there's an artifact, almost always it hinders our ability. It gets in the way, it hinders our ability to make a diagnosis. It makes a picture ugly, whatever. But some of the ultrasound artifacts actually help us make a diagnosis. And that's why we had to spend a little time talking about physics, which you'll understand here in a minute. The first one that I want to describe as an artifact isn't really an artifact. It's just you get a shitty image. You get a poor quality image. Okay. The liver looks ugly. The spleen looks ugly. Okay. There are several reasons that can cause a poor quality image on ultrasound. The most common one is going to be improper patient preparation. You didn't take the time to clip the hair. Okay. That it's got not enough lube. You didn't use enough gel. The gel that you put on the skin surface actually helps the ultrasound to get out of the probe and get into the animal. If you don't put gel on the skin surface, no matter how hard you push, there's going to be a very thin, finite layer of air between the probe and the skin surface, and ultrasound doesn't penetrate through air. Okay. And so you get a really ugly image. And so that's why you put that coupling gel, the ultrasound gel, on there. You can also use water. You can use alcohol to put on there too. Problem with those, they evaporate really quickly and you're constantly putting more on there. So the ultrasound gel works out a lot better. And so take the time to prepare the animal, clip the hair, use the lube, use the gel, all that kind of stuff, and it'll make your picture a lot prettier. Other things that will inhibit quality of ultrasounds, okay? Obesity, okay? If you have a really fat animal, the ultrasound image quality is going to just be poor, and there's not much you can do about it. It's just fat. On the other hand, the radiographs are going to be great, but the ultrasound is going to be poor, okay? You've also probably seen some of these animals that come in and they just have really thick, nasty skin problems, kind of fibrotic skin, really thick skin, stuff like that. Some of the Shar-Pays, no matter how much you clip the Shar-Pays, they don't image very well because they have that weird hair on them, and so they don't image well. Thick skin, not enough gel. Again, don't be afraid to put gel on there. Gas. Ultrasound does not penetrate through gas. Okay, it doesn't penetrate. If you hold an ultrasound probe to the air, you won't see a damn thing on your machine. Okay, it doesn't penetrate through air. Okay, something that high frequency won't penetrate through air. And so again, if I put it in the abdomen and I find the stomach, if the stomach's full of gas, I can't see anything in the stomach. Ultrasound will not penetrate through gas. I can't see anything through gas. Okay, you can't use ultrasound really to look inside the lung because the lung is full of air. Okay, radiographs you would use. Okay, so ultrasound, if you have a lot of gas in the belly and the small bowel, it's going to inhibit the ability to do ultrasound because you have a lot of gas inside the bowel. And the other thing is your machine's not set up properly. The gain's too low, the depth of the image is too high or too low. So you don't know how to work the machine, you don't know what the knobs do, and the machine's not set up properly will cause poor image quality. So here's an example. So again, ultrasound is a form of cross-sectional imaging, just like CT and MRI is. And it allows us to get slices of whatever plane we have the probe turned at, one slice of a particular organ. Okay, so we're not looking, it's not like a radiograph where we have the whole abdomen and everything's kind of summated on top of, all the organs are kind of smashed on top of each other, and we have to try to see around that. Okay, with ultrasound, just like CT and MRI, we're getting a slice of a particular organ, which is nice. Okay, but here is a slice. This is part of a kidney right in here, but the image quality is so poor. Okay, if I didn't know for sure that was a kidney and had a probe in my hand and it wasn't labeled as such, I'm not sure I could tell you that's a kidney. And I sure couldn't tell you if it's the right or left kidney. And I sure couldn't tell you exactly where on the probe, on the dog's belly, the abdomen, this probe was sitting at. I don't know if it's caudal, ventral, left, right, or whatever. I don't know. Okay, so we have to be really specific with ultrasound. So if you get in the habit of doing ultrasounds, always label the left kidney, label what organ you're looking at, whether it's the left side, right side, midline, whatever. Because I can guarantee you, if you come back a year later and you compare and you look at this and it wasn't labeled, you're not going to remember if that's the left or the right. You might even not know if it's a kidney. Okay, so take the time to label the images. The gel that you will buy for ultrasound, the cheapest way, it comes in these catch-up bottles here, but the cheapest way is you can buy these gallon jugs of ultrasound gel, and you buy them by the case, which is usually 4 or 6 of these big gallon jugs, and then you can use this to refill the catch-up bottles. Okay, and that way it's really cheap. Okay, another ultrasound artifact that we have to talk about is posterior shadowing, and this is one that will actually help you make a diagnosis. With this artifact is one you're going to use all the time to help diagnose a stone in the urinary bladder, among other things. But the most common would be a stone in the bladder. So let's look at this picture. We're going to describe posterior shadowing. Here's an ultrasound of the urinary bladder. Okay, the bladder is this organ. This is part of the bladder wall here. Okay, this is on the ventral aspect of the abdominal wall, so in the dog's belly and the caudal abdomen. Here's the bladder. The bladder normally is full of anechoic black fluid, which is all this stuff around it. But in this particular case, I have a stone in the bladder. Okay, well, the animal's lying on his back, so the stone is going to go down to the dependent portion of the bladder, so it's down this way. Okay, and that stone has a nice crisp white line and has this shadowing afterwards, or this posterior shadowing after the stone. So how does that form? How does that work? Well, basically, I have my ultrasound probe up here on the skin surface. It shoots ultrasounds down this way. Okay, they're going through the bladder, and then everything's great. It's going through this fluid bladder. Nothing's impeded until it gets to this mineralized stone that's sitting inside the bladder. And again, ultrasound will not penetrate through gas. It also won't penetrate through bone or metal. Okay, it's too dense. And so the ultrasound comes in here. 100% of that ultrasound is reflected back towards the probe, which is why you get this crisp white line. That's the edge of that bladder stone. Okay, because 100% of the sound is reflected back to generate this picture, there's no sound left to go further deeper. Okay, so we have no sound down in here because all of it has been reflected from the surface of the stone back towards the probe. So posterior shadowing is used typically to define a stone that's made out of some type of mineral material inside of that urinary bladder. Posterior shadowing, okay? Another artifact that we can talk about is called reverberation artifact. And let's look at a picture on this. So now let's say we have two interfaces that the sound wave can reflect off of. Interface A, or the capsule of the kidney A, and a subcapsule B. Okay, here's my ultrasound probe, and I send out a volley of sound at time 1, and the length of the ultrasound is, let's say it represents the length of these arrows. So it's going to go out, and these arrows are going to move from left to right. Okay, as they interact with surface A, a portion, let's say 50% of that sound, is reflected off of surface A and reflects back towards the probe. And over time, it'll get back to the probe, and then it'll create a picture with a white line that represents surface A. On the other hand, the other 50% of that sound will penetrate through A and then turn around and reflect off B back towards the probe. So we get a second volley of sound that comes back towards the probe that over time will hit the probe surface and will create a second white line. Okay. So we get two individual, that's again, we're back into that resolution thing. Okay. We get two surfaces that have enough distance between them where we will get two separate white lines on our ultrasound machine picture. Okay. If those surfaces now are so close together, then this tail end of this sound wave will ride on the back end of this one, and we won't be able to see there's two different lines. When that happens, we can get this artifact, which is called a reverberation artifact. So we end up getting, this is a section of bowel, and inside the middle of that bowel is a thin, crisp white line that you can see right in here. And what that is really is just a little bit of gas inside that bowel loop. And ultrasound doesn't like gas. They don't get along very well. It doesn't penetrate through gas, okay? So what we end up getting is we get a bowel loop that sits up in here, but then we get a reverberation artifact, which it looks like now there's another bowel loop here. There's another bowel loop here, another bowel loop here, another bowel loop here. So we get these parallel white lines that are stacked right on top of each other. They all look the same, but the thing is that as they get deeper and deeper and deeper, they get less and less more obvious. Okay, so they become weaker and weaker the deeper they get because the sound is then used up. And what's ends up happening is we get a sound wave comes into that lumen and it kind of recycles around inside the lumen. Okay, the reverberation artifact will cause these white lines that you can see that are parallel to each other as they get deeper into the tissues and less apparent. Okay, if they're stacked on top of each other so quickly, then they get what's called a comet tail artifact. So this is liver, this is part of the stomach, and we have a little gas bubble here in the stomach, and that sound gets lost in the gas bubble and causes this reverberation or comet tail artifact. That comes just a little bit of gas inside the stomach. So that's an artifact that will kind of hinder us and get in the way. Obviously, if he has food or something in the stomach, I'm not going to be able to see it because this artifact's in the way. Okay, a slice thickness artifact. This is another one we have to worry about. Here's our ultrasound probe here. And again, this is cross-sectional imaging when we talk about ultrasound, and it generates a slice that we can get information of through a kidney or through a part of the liver or whatever. If I look at this picture here, this is all liver tissue here, but I'm looking at one slice that may be a millimeter thick of this liver, okay? If I'm looking at that one slice of the liver, I can tell in that 1 millimeter thick slice, everything looks pretty normal. But can I tell you about the rest of the liver? I can't tell you about what the rest of the liver looks like. It may look normal also, but next to this slice, it could be a big mass. I don't know. So that's why you have to fan the probe around to look at the entire liver. Okay, so there's a definite slice thickness when we're looking at this. And let me do this. So here's a magazine. Here's JADMA, right? Okay. Well, this magazine has a particular thickness to it. Okay, it's not very thick, not a whole lot of information in it, really, mostly ads, right? But we can use it for our example. So if I have my ultrasound probe and I'm doing it this way and I'm scanning you, I'm going to get a slice. Okay, here's that picture right here. You can see here's a slice of the urinary bladder. Okay, so if I'm on the edge of the bladder, what's going to happen? The slice thickness artifact, I'm going to get certain numbers of pages, this many pages. Okay, that is going to go inside the lumen of the bladder. And that's going to give us our picture of black fluid inside the bladder with this many pages. Okay. But then I'm going to get 2 pages, if I can get to them, 2 pages right here, right? That's going to go through the bladder wall. Okay. And that's going to give us our picture right here of the bladder wall. But then I'm going to get the 3rd section, which is all the rest of this slice thickness. That's going to go outside of the bladder. And what's next to the outside of the bladder is usually a little bit of mesenteric fat. Okay. So I get part of that slice thickness that goes inside the bladder wall, this part right in here. I get part of the slice thickness that goes through the bladder wall itself. And then I get a part of it that goes outside the bladder. Well, all of that sound as it goes inside the bladder, through the bladder wall, and outside the bladder is reflected back towards the machine. It's just a computer, so it averages all of those pictures and puts them all together in one picture that you see. So the slice thickness artifact, typically you're going to see mostly on the urinary bladder, and it will cause this. This looks like there's debris or cellular debris in the dependent portion of the bladder. But all that really is part of that slice that's going outside of the bladder, and you're seeing echoes from fat around the bladder that now looks like it's in the bladder, but it's not. Okay, so how do you decide? If you have debris like that in the bladder, which we're going to learn about, that's a sign of cystitis or an infection or blood inside the bladder. So what's a veterinarian to do? How are you supposed to decide? Is that real or is that artifact? Well, you can do a few things. One is you can turn your probe. This bladder is in longitudinal section, right to left, so cranial to caudal. You can turn your probe now where it's cross-sectional. And if that's artifact, it will tend to go off to one side or the other. The other thing that you can do is you can vigorously shake up the bladder as you're doing this and stop and see if that's fluid in the bladder, if that's blood cells or white blood cells or red blood cells, then you can real time, you can see it kind of swirling around like a snow globe. Okay. And that will tell you if it's real or not. And the other thing that you can do is you can stand the dog up. Right now he's lying on his back when you're ultrasounding, but you can stand him up, have him stand up on all fours, and ultrasound it from underneath. And if that's real inside the bladder, now it's going to fall down to this part of the bladder instead of being in that part of the bladder. So those are some things that you can do to try to convince yourself, is this debris looking stuff down in here in the bladder, is that real and real debris in the bladder, or is it due to this slice thickness artifact? Okay, so those are the three things that you can do to try to help yourself. Okay, another one, and this one's kind of interesting. An artifact will only happen typically on the edge of the diaphragm. Let me go back and show you this picture right here, okay? So again, whenever by convention, whenever we're doing ultrasounds, we typically have the probe, the longitudinal long axis of the probe is going to be in the same long axis of the dog. So they're kind of parallel to each other. The conventional way, whenever we do ultrasounds of any body part in a dog, is we do hanging protocols the same as we talked about when we put up x-rays. So we always put cranial to the left by convention. So everything this way is to the cranial side of the dog. So the head's this way, tail is this way, so caudal this way. Okay, same as you'd hang a radiograph. So, and then we have the probe on the ventral aspect of the abdomen here. And then this is dorsal. So this is stomach. There's our comet tail artifact we talked about. Here's part of the stomach wall, which we're going to talk more in depth about, bowel wall. This is all liver in here. This is all the way the liver looks. This is blood vessels in the liver, which we're going to talk about what those are. This is probably a little subcutaneous fat on the, the ventral aspect of the body wall. This white line here is the diaphragm. So this is the diaphragm that divides the abdominal cavity versus the thoracic cavity. Okay, so the only place that you're going to see this mirror image artifact that we're talking about is on the edge of the liver, where you have this curvilinear diaphragm. What ends up happening with this slice thickness artifact is, here's the edge of the liver. This is part of the gallbladder. But if you look here, it almost looks like there's part of the gallbladder and part of the liver that's on the other side of the diaphragm. Okay, and this is caused by a phenomenon called mirror image artifact, that early on when they started doing this in people, they opened up a lot of people's belly because the radiologists were diagnosing that they had a diaphragmatic hernia. They had liver and gallbladder on the other side of the diaphragm. And surgeons would get in there and say, no, they don't have a hernia, they're fine. Okay. So the mirror image artifact only happens on the edge of the liver near the diaphragm, to where it looks like there's gallbladder and there may be liver on the other side of the diaphragm, but there's not. Okay. So you just have to realize that. And the key is, look at the diaphragm itself. There's not a hole in it. There's not a tear in it. It's complete. Okay. That's the only place you'll ever see the mirror image artifact. Another artifact we have to talk about is posterior enhancement. A minute ago, when we talked about bladder stones, this one here, we talked about posterior shadowing, okay, to where 100% of the sound's reflected back towards the probe, leaving no sound to go further, and it causes shadowing right in here. And typically we see that with a stone inside the urinary bladder or gallbladder, okay? Posterior enhancement is the opposite, okay? Posterior enhancement is where we actually see increased sound after a structure. So here's the edge of a gallbladder here. This is liver, this is the diaphragm, okay? But note that the liver tissue on the other side of this cystic thing, which is the gallbladder, looks brighter than the liver next to it at the same depth, okay? So posterior enhancement is used sonographically to define a cyst, okay? This is the gallbladder, but basically it's a big cyst. It's a thin-walled, fluid-filled structure, okay? So there's so much energy left after it penetrates through this cyst of the sound waves that the tissue deeper to that cyst shows up brighter white. Okay, it's more echogenic than the normal liver next to it. Okay, so that artifact, posterior enhancement, is used to define a cyst. Sonographically, a cyst is defined as something that is thin-walled, filled with anechoic fluid, that generates posterior enhancement. That is the definition of a cyst sonographically. Okay, and why is that important? It's important because most cysts are almost always benign. Okay, they can get big, they can cause problem and push on things, but they're not malignant. So it's kind of nice to be able to define a cyst. Okay, now we're going to talk about livers. And actually, we got 10 minutes left. This is a really good place to stop. So let's stop today, and then we're going to come back tomorrow and start talking about livers and then spleens and gallbladders and stuff like that. Is that cool? Okay, sorry, the physics part of it's boring, but and it's the Zoom remote feature doesn't help with any of this. So anyway, y'all have a good rest of your day. We'll see you tomorrow morning at 8 o'clock. Bye.